A very good day, my dear undergraduate and emerging postgraduate students. Welcome to What Next? Something is staring at all of us, and I want the diagnosis. What can you people observe? This is obviously an autopsy specimen from a 55-year-old male. What are the changes seen externally? The clinical history gave an immunological etiology. Diagnosis. Thanks to Wikipedia for this wonderful picture. I find the blood vessels that are having a kind of a beaded appearance. I hope you people are able to observe it. And this is called a rosary appearance. Diagnosis still. This term can be used in other contexts. We shall be seeing them later. Coming to the blood vessels, the vasculitis, there can be large vessel such as the giant cell Takayasu's and then medium-sized arteries. And there can be the polyarteritis and the Kawasaki's disease. R.A.T.S or the small arteries can be affected. They can be in a case of microscopic polyangiitis, etc. Finally, the small arterioles or even the glomeruli can be affected. Multiple capillaries can be affected in inox-covalent blood. Therefore, we should be familiar with the age and then the caliber of the blood vessel. Third one should be the distribution. The diagnosis in our case is polyarteritis nodosa. So probably nodosa, it comes from this. It is systemic. It affects the small and medium-sized muscular arteries, not capillaries. Common between the 5th and 6th decades. No ANCA. What is this ANCA? Anti-nuclear, neutrophilic, cytoplasmic antibodies. 30% of the cases are supposed to be associated with hepatitis. They say hepatitis B. It can be idiopathic, cutaneous, and hepatitis associated. Normally, you find that a particular segment is affected, and then there is a transmural necrotizing lesion. Transmural means it involves the entire thickness, intima, media, adventitia. The common organs which are affected are kidney, heart, liver, GAT. The distractor can be the lung, which is very uncommon, not affected by polyarteritis nodosa. And ANCA means anti-neutrophil cytoplasmic antibodies. This occurs in vasculitis. A very good picture, thanks to this particular person. Rubin and Farber used to be a wonderful textbook. If possible, I would recommend you people to that. Very lucid reading. And thanks to them for the wonderful information provided. It affects the medium-sized arteries. Ischemia. Nervous system can be affected. Renal arteries. GAT. Skin. Livedo reticularis. That is the name that is given for. PAN. It can be systemic or cutaneous. Secondary to hepatitis B virus. Some people say C virus also. Rheumatoid arthritis. Because immunological again. Mostly beyond 50 years of age. And there can be a spiraling of the blood vessel that is seen. Subcutaneous nodules, gangrene of the extremities. Look at this again, gangrene of the extremities. Ulcers can be seen. And this is some kind of a diagram that has been drawn. Livedo reticularis. Have this in mind because I'm going to show you a picture towards the end. Polyarteritis nodosa is also called panarteritis nodosa, periarteritis nodosa, Kussmaul-Meyer disease, Kussmaul's disease, all of the above. Please go and find it. And see what is happening in a case of polyarteritis nodosa. One, there is an inflammation, therefore there is a compromise in the lumen. Sometimes there can be a luminal occlusion. There might be a thrombus formation, or there can be a massive edema of the walls. Aneurysm, obviously. Aneurysm. It can occur in infections. We call it as mycotic, or in inflammation, such as polyarthritis nodosa. So, aneurysms, there will be a fibrinoid necrosis, thickening, inflammation, and many of the stages can coexist. Patient can present with a weight loss, not very specific, lividio reticularis, and hyperlipidemia. Other autoimmune diseases can be there. Testicular pain, maybe again because of vascular compromise. Mononeuropathy, sustained hypertension. Hepatitis we had mentioned, aneurysms, fibrinoid necrosis. So most of them are again given on the box. I would like you people to kindly see this histological picture. This is what we usually get. So there is a lumen filled with RBCs, a congestion obviously. The endothelium. Then there is a loose lamina propria. There can be the smooth muscle. I hope you people are able to appreciate the spindle-shaped cells over here also. So the entire thing is a smooth muscle. Externally also, I'm finding this. Look at this flower-shaped cells. They are all the neutrophils. So it is pan involving the entire thickness. More important is the eosinophilic acellular material, which is fibrinoid necrosis. So lack of the endothelial cells, fibrinoid necrosis, transmural inflammation. The associated diseases can be hepatitis B or C, hairy cell leukemia, and enzymes associated ADA. What is this ADA? Ultrasound will be showing asymmetric kidneys. Biopsy can show mononuclear infiltrate, fibrinoid necrosis, arteriogram for micronecrosis. And the prognosis is usually good if treated early with steroids, cyclophosphamide. Death is rare and can be due to renal failure, myocardial infarction, or stroke. Now, what is this one? So, there is a basic defect in this case, and it is the mutation of adenosine deaminase 2. Adenosine deaminase. So it comes to ADA. It is a polyarthritis nodosa vasculopathy, thanks to this particular source from New England Journal of Medicine. There is a gangrene of the toes that can be seen. There is an erythema. There is an area of fibrinoid necrosis. And also there is an aneurysm that can be seen in one of the vessels. The mutant adenosine deaminase 2 in polyarthritis nodosa. See you again. What next?